Skin cancer treatment is not a menu of interchangeable procedures. The right treatment begins with the exact cancer, its risk, its location, and how confidently the margins must be known. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Wait, before we dive into the details, is skin cancer really just one disease with one best treatment? I mean, if you're a patient sitting in a clinic, isn't it basically all the same condition that just needs the same simple cut?
Actually, no. That is a super common misconception. But skin cancer is absolutely not just one disease. These cancers behave entirely differently. Take basal cell carcinoma, or BCC. It rarely spreads, but it can grow deep, it can recur, and it can cause serious damage to important local structures. Then you have cutaneous squamous cell carcinoma, or CSCC. That's mostly cured locally, but the higher-risk tumors, they can actually spread to lymph nodes or even distant organs. And melanoma? That's a completely different beast. Its treatment depends heavily on things like depth, ulceration, and stage. Plus, there are rare skin cancers that follow their own highly specific lineage rules, so you literally cannot declare one treatment as the best for a patient without first naming the exact cancer and the clinical problem they're facing.
Okay, let's quickly level the playing field so we fully understand the clinical goals here. Let's translate some of that essential medical jargon. A margin is simply the invisible boundary around and beneath a removed cancer. Recurrence means the cancer returns after a prior treatment, while metastasis means it's actually spread beyond the primary site. A local treatment addresses just that primary spot on the skin, whereas a systemic treatment circulates through your entire body. Finally, adjuvant treatment is extra therapy added after the main procedure to reduce risk, and definitive treatment is your primary attempt at a cure. Having these terms down really helps us understand what we're actually trying to achieve in any patient scenario. Now let's look at the foundational concept of surgical margins, because cancer often extends way beyond what the naked eye can see. With standard excision, the surgeon removes a planned rim of normal-appearing skin, right? And then the pathologist examines sampled representative sections afterward. Mohs surgery, on the other hand, is entirely different. Mohs completely maps and examines the peripheral and deep margin during the operation, looking at it as a continuous end-face surface. If any cancer remains, more tissue is removed only from that exact positive location. This deliberately preserves your normal, healthy tissue. Let's pause and reset for a second. If both standard excision and Mohs are physically cutting out the cancer, why does a specific type of surgery actually matter? Does margin control really change the patient's outcome all that much?
It absolutely changes the outcome, and the evidence here is incredibly compelling. Look at the striking data from a landmark 10-year randomized trial for recurrent facial basal cell carcinoma. The tumors came back in just 3.9% of cases after Mohs surgery. Now compare that to a 13.5% recurrence rate after standard excision. Think about that. For a facial cancer that has already returned once, precise, complete margin mapping reduces the long-term recurrence rate by roughly 2/3.
And this advantage extends far beyond just local recurrence for high-risk tumors. In a 12-site observational cohort of 2,752 very high-risk cutaneous squamous cell carcinomas, complete margin assessment with Mohs was associated with lower 3-year local recurrence, lower nodal metastasis, lower distant metastasis, and tragically, lower disease-specific death compared to vertical section excision. Literally every single measured cancer outcome favored the complete margin group. It's an absolutely critical part of the oncologic strategy.
But wait a minute. Does this exact same logic apply to melanoma?
Yes, for sure. Selected melanoma evidence also heavily supports margin-controlled surgery. In a long-term cohort of 662 melanoma in situ, recurrence was just 1.8% after Mohs, compared with 5.7% after wide local excision. And if we look at invasive disease, a huge registry study of head and neck invasive melanoma reported a 5-year disease-specific survival of 92% after Mohs compared to 82% after wide local excision. That 92% survival figure, that's a crucial takeaway. When preserving tissue matters in constrained sites like the head and neck, modern evidence solidly backs this approach. But here's the catch. Using Mohs for melanoma has very strict rules. It absolutely requires melanoma-specific pathology and immunostains to be accurate. On top of that, the central debulking specimen must be analyzed with permanent sections to provide complete staging information. You simply cannot skip those steps. When it's utilized in properly selected patients within experienced programs, it provides excellent local control.
Okay, so with numbers like that, does that mean Mohs is necessary for every single skin cancer a patient might get?
Oh, not at all. Actually, standard excision is an excellent standard choice for many primary, well-defined tumors where a planned margin can be removed safely and easily. It's also the standard local operation for most invasive melanomas when guideline margins fit easily. The main limitation of standard excision is margin sampling. Now, that's entirely reasonable for a straightforward low-risk tumor, but it really becomes a problem when that invisible border is unpredictable.
What about the simpler stuff? Like scraping or using those prescription creams. Can they replace surgery for our patient?
Well, curettage, which is scraping, and topical therapies can certainly fit carefully selected superficial or lower risk cancers, but the trade-off there is significant. They don't provide an oriented, complete microscopic margin. Because they lack that certainty, they're simply not a good fit for aggressive, recurrent, or high-stakes disease. The word cream doesn't mean ineffective, but it absolutely does not mean it's equivalent to margin-controlled surgery.
And what if the patient just flat out refuses surgery? Or maybe it's just not physically safe to operate?
Right, that's exactly where radiation comes in. Radiation is a completely legitimate treatment when surgery is declined or just not feasible. However, radiation treats a field in place over multiple sessions, and its response is followed clinically. It essentially substitutes a treated field for surgical removal. That means you don't get an X-sized microscopic margin to confirm that the cancer is 100% gone. So it's a sensible trade when surgery isn't a good fit, but it is not an automatic equal substitute for Mohs in a margin-critical tumor.
For even more complex scenarios, systemic therapy is used when the disease is locally advanced or involves lymph nodes and just can't be managed by local treatment alone. On the completely opposite end of the spectrum, observation without immediate treatment is only a defensible choice in very narrow situations. Specifically, that's when a patient's competing health risks or limited life expectancy clearly outbalance the likely benefits of doing an intervention.
So, bringing this all together, a logical plan for a patient really follows a diagnosis-first decision path. Step 1 is always identifying the exact diagnosis and risk. Step 2 is determining your margin needs based on that specific tumor. Step 3 is selecting the actual treatment, whether that's simple excision, Mohs, or utilizing radiation as an alternative when surgery isn't feasible. And finally, step 4 is planning the reconstruction.
But before a patient jumps into that final step, reconstruction, aren't there some critical questions they need to ask their clinician?
Absolutely. You really have to ask, what happens if the treatment fails? And what will we actually know before reconstruction begins? You need to choose the diagnosis-specific pathway first, and then ask which treatment gives the absolute best balance of cure, margin certainty, and tissue preservation. As a patient, you must know if your margins will be definitively confirmed clear before a major repair even begins.
The most memorable takeaway here is that you simply cannot treat skin cancer as a one-size-fits-all scenario. Precise, evidence-based choices dictate the outcome. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. We highly encourage you to read the complete Skin Trust article to discuss individual decisions with your treating clinician. And if you're wondering what happens next, check out our explainer on Skin Trust regarding reconstruction options.